Good morning, everyone. If you're just, I think people are in their in the modern tech way. I was wondering what the word is. Is it shuffling into the room or stumbling into a room, or I don't know what the verb is for entering a Teams call. But you're very welcome if you're just joining. Um, my name is Alex Bax. I'm Chief Executive of Pathway. I'm your host and chair this morning. I'll do some of the presenting and some other colleagues I'll introduce shortly. We've got quite a lot of people expected this morning, so we'll just give a bit of time for people to join the call. Maybe I'll do a little bit of housekeeping just as people do come on the call this morning. I'm going to tell you a bit about the structure of this morning's session in a minute, but just practical housekeeping. As you come in, we're trying to automatically mute people to avoid that horrible kind of background noise you can get on a Teams call. There will be a Q&A and discussion session at the end of our talking part of the presentation this morning, and we will have to unmute you. You won't be able to unmute yourself. So when you put your hand up, please wait for us to unmute you. At the same time, please do, as we're speaking, if questions occur to you, please do place them in the chat and we'll keep an eye on them and try and deal with those. Some of them, they're very practical. We'll try and deal with them as we're going along, but we'll gather them up and answer them also at the end. Could I also say to people joining that, of course, you're very welcome. And please do take a moment to introduce yourself to colleagues in the chat this morning. There are quite a lot of people on the call from all over the country. So really nice, I always think, for colleagues to know where others are coming from. So yeah, please do use the chat function. Other bit of housekeeping, this event is being recorded this morning. We will be placing the recording on Pathway's YouTube channel. If you've not visited Pathway's YouTube channel, do look it up. And also probably on the NHS Futures website, where we also post content. So again, when it gets to Q&A, if there's something you don't want to go fully into the public domain, don't say it, I guess. Or if you want to ask about a patient or something, keep it suitably and appropriately anonymized. So yeah, I think we've got a good number of colleagues here now. So welcome again. My name is Alex Bax. I am Chief Executive of Pathway, the homeless inclusion health charity. And you're in the right place if you think you're coming to a Pathway showcase session where we'll be telling you about the Pathway Partnership Programme. And as this slide says, how we can help you in your system improve outcomes for your homeless population, save money within your system, and help to shift demands from hospital to the community. And that's by delivering better care, more connected, more integrated care. I'm going to make sure and see if I can get the slides to move on. The structure of the talk this morning, we're going to share with you the problem, how we see it, and what the issues around people experiencing homelessness coming into hospital, what issues that creates for the system, and what's happening for people in that position. A bit about our solution, what the Pathway Partnership Programme offers you, and what a Pathway team in a hospital does to address the needs in the patient group and to help the system. The evidence behind that intervention, and we have an extensive array of evidence in support of this intervention. And then a bit about how Pathway can work with you to help you implement this system and to make other improvements in your local place. And as I said, at the end of that, there'll be some time for Q&A and discussion and a little bit about next steps and how you can keep in touch with us and get in touch to follow up. Just to introduce one colleague who will be speaking after me this morning, Dr. Chris Sargent. I'm pleased joins us this morning. Chris is Pathway's medical director. He's also chairman of Arch Community Research Company. Arch is the specialist homeless primary care, and actually a much wider array of services Arch deliver in Brighton. Chris has got over 25 years experience of delivering specialist care for patients experiencing homelessness, including a Pathway team intervention, leading the team in Brighton at Sussex University Hospital for many years. We're also joined this morning by two very special guests, and welcome. I'm going to keep your names secret now. I'm going to introduce them as we get to them. Both are coming as volunteers this morning, so thank them both now for giving their time to us this morning, and they will give us both a patient perspective on the matter in front of us this morning and a commissioner perspective. So I'll introduce those guests as we get to them. And when I bring those colleagues in, I'm going to drop the slide so you can see us a bit better. But to begin with, I'm going to just talk you through the problem we're here to help you solve, which is homelessness in a hospital. And within Pathway, we always start our management meetings, our board meetings, ideally with a case study, trying to think about a patient. So we thought that was the right way to start our presentations to you this morning. So this is just to introduce you to a young man called Arthur, who was admitted to a South London hospital as an emergency a couple of years ago. This is a case study from one of our teams. He's a young man. The family had been shockingly his family had been living in a storage container immediately before this admission. It's a history of a serious gunshot wound, multiple episodes of surgery, a stoma, having IV nutrition. In this admission, he's admitted with sepsis and an acute kidney injury. The Pathway team, the hospital team, got to this patient's bedside on the day of his admission and began to find out what had happened to him. And amongst other things, we're going to come back to Arthur later, but amongst other things, they were able to evidence that he had in the previous year 33 inpatient episodes of care, 6 attendances to A&E which did not result in admission, and 30 outpatient appointments, many of which he had missed because he had quite a lot of other stuff to manage in his life, given his housing and wider circumstances. So this is Arthur. And in his case, you can see a picture of the complexity that homelessness visits on people in their lives. But what else do we know about homelessness and hospital use? So these figures are from an early study Pathway commissioned from actually the then chief analyst at the Department of Health. And reviewing data nationally, he found that people experiencing homelessness attend A&E 6 times as often as the housed population, are admitted 4 times as often as the housed population, and stay 3 times as long. Those high rates of admission relate to them being 2 to 3 times as sick as the housed patient who attends hospital and is admitted. And also in this study, he estimated that secondary care costs incurred were 8 times the rate generated around the housed population's use of secondary care. So those admissions racking up costs. I already alluded to this in relation to Arthur's case. This patient group arrives in hospital with a high level of complexity. Within the homeless and inclusion health world, we talk about trimorbidity. This is the combination of a physical health problem. Of course, if you've come to hospital and if you've been admitted, you plainly have a physical health problem. But in our population, trimorbidity means not only a physical health problem, but also a mental health problem and issues with substance misuse. And fully 30% of the patients in our population group present with all 3 issues at the same time in hospital. Many other layers of complexity also, as alluded to on this slide, that our housing system in the UK, incredibly difficult to navigate, incredibly defended in terms of finance and access. Layers of complexity also in social care, colleagues will be aware of. And this all adds up to a complex patient in secondary care. And where there's no specialist team, mainstream hospital staff will often struggle to deliver good care for this patient because of that complexity and because they may not be trained in all the issues that can combine in this patient group to create challenge. Another way, and a study one of our Pathway clinical fellows published this summer in The Lancet, another angle on that degree of health need in the population. This is an examination of frailty. You see on the left there, 42% of people experiencing homelessness found to be clinically frail. The age profile of this population is young. So this is a really shocking figure. And on the right, 25% of the under 30-year-olds in our group are clinically frail. I think the rate in the general population is 2%. So again, this is 10 times the rate of early onset, extremely early onset frailty. And this alludes to we talk in our world about stark premature aging, and these studies of frailty are helping us evidence that even more. Other disease burdens: 6 times more likely to have heart disease, 5 times more likely to have a stroke, 34 times more likely to present with TB. This is a patient group with multiple health needs who very sensibly and helpfully are coming into hospital where they should and could get good care to help them with their needs. All of those prior studies perhaps were best composited and many other studies in this large paper, again, a meta-review produced with us in The Lancet in 2017, summing, if you like, all of that need through calculating standardized mortality ratios for our population. Across the bottom of the slide, we have the Michael Marmot gradient from rich to poor of deprivation against standardized mortality ratio. And then on the same scale, we've put in the rates calculated in this study for the homeless multiple exclusion population. And you can see a shocking discontinuity in this graph. We talk about a cliff edge of health disparity with rates, as it says here, for 8 times higher standardized mortality ratio in the male group and 12 times higher in the female group. The average age of death for a homeless woman is 43 and the average age of death for a man is 45. That's where that frailty work really speaks, because patients stuck in homelessness are aging fast and at high risk of early death. And all of this health need adds up to significant cost, as I alluded to at the beginning. The teams in our current program, we estimate on average see around 600 homeless patients per annum in a hospital. Based just on standard care costs, we think that adds up to around £5 million of cost per trust in terms of homeless patient care. As I said, many studies suggest the disease burden and the need, and therefore the cost in secondary care is much higher, up to 3 to 8 times higher than that figure. And finally, as we think about need, out there in the real world, out there in the world outside the NHS, I'm afraid that rates of rough sleeping continue to rise, up 20% in the last 12 months. Numbers of families in temporary accommodation also rising, up 12% in the last 12 months. So the need out there in the general population is rising, and this means people will come into hospital. We have an identifiable group of patients with high needs, high health risks, and if nothing changes for them, their health will continue to deteriorate. Fortunately, they come to hospital, but with standard care, the outcomes can be poor and patients will keep coming back. So that's the business as usual scenario we're challenging you with this morning. So now I'm going to introduce Chris Sargent, Dr. Chris Sargent, who's Pathways Medical Director. Chris is going to tell you a little bit about the Pathway team intervention, our response to this high need and what we can do about it. Chris, welcome. Hope you've got a cup of coffee or charged this morning.
I have. Thank you very much.
Over to you,
Alex. Thank you, Alex. So Alex has done a good job there of outlining what the problem is, and the solution is Pathway teams as part of the Pathway Partnership Programme. Next slide, please. So what is a Pathway team? So a Pathway team is an in-reach team which is located in a hospital. It's GP-led, multidisciplinary, so we get the benefit from the training and experience of different disciplines. This is one of our teams in South London, so as GP in the middle. The teams then can consist of a combination of nurses, physios, OT, social workers, housing workers, support workers, and some of the teams have care coordinators, care navigators who are people with lived experience of homelessness in the past themselves. And the teams are evidence-based. So we've got a strong evidence base for the outcomes for the teams, which we'll talk a little bit more about later. So what do the teams do? They improve safety, both of the admission and of the discharge, the quality of the admission and the discharge, and the flow through the hospital. So they do this by undertaking a holistic health assessments. So when you go to hospital these days, it's likely that your presenting problem, the thing you came with, will be well dealt with, but not much else. And obviously we know with our population there's a lot else going on. So there are many different issues that need to be dealt with, and hospital admission is a good opportunity for that. They undertake clinical advocacy. So they deal with all the different teams within the hospital. They'll follow the person around the hospital if they get sent to different units. They come in again, they'll be seen again, even if it's for a different problem. And they coordinate the care of the different teams within the hospital and outside of the hospital, so bringing the community teams in. They undertake multidisciplinary team planning and service integration. So they'll hold a multidisciplinary team meeting once a week, inviting people from the community, so housing, mental health services, substance misuse services to come in to talk about the person while they're in hospital to plan for when they're discharged. Planning discharge is one of the big things, so making sure that the person has the services that they need out in the community when they're ready to go. So there isn't a delay, there's no delay of discharge, and all the services are ready at the right time. So they start to plan for discharge as soon as the person's admitted. They also act as a good link to step down. So intermediate care specialist step down is where there's a facility that people can continue their recovery after they're discharged from hospital if they're not ready to return to their accommodation, or if they haven't got any accommodation to return to. So the teams act as a really good link to make sure the right people go to that facility, is used in the right way. And they also undertake training and education for people both within the hospital and in the community. So they'll meet new cohorts of staff. They'll talk to people when they start to work in A&E, educate medical students, whoever's available to educate, they will educate them. So going back to Arthur's story, so Arthur is obviously a anonymized person. It's not his real name. What did the team do for Arthur? So they coordinated the care across multiple medical teams. He had about 10 or 12 teams involved, needed a lot of coordination to make sure they're all talking to each other, not taking decisions which negatively affected what other people were trying to do. They provided emotional support for Arthur's family and him, and liaised with his GP. They helped to find suitable accommodation for him when he was discharged. They put in an initial housing application, which resulted in an offer of housing which was not suitable for him given his problems. So they were able to appeal that, and the GP was able to provide medical information to make sure that was successful. And then they helped to manage him post-discharge. So made sure that he had the things he needed to go to his new accommodation to make that comfortable, that his housing benefit was running, so he didn't then get affected for non-payment. He was registered with a new GP in his new area, and they were able to access post-traumatic stress disorder counselling for him as well. So as I say, this isn't actually Arthur, it's not a picture of him, but it's somebody in a similar situation to him. So what's happening to Arthur now? He's now thriving in long-term social housing. He's actively engaged with healthcare and his health. And since the team became involved, he's had no emergency admissions or A&E visits to the hospital, which is in stark contrast to how things were when he was admitted. He hasn't missed any appointments around his health in the 6 months post-discharge. So all his care is now in the community. It's planned care, which is obviously better for him, it's better for the system, and much cheaper to deliver. That's my last slide. Thank you.
Chris, thank you very, very much. And colleagues, I hope that's given you a quick snapshot of what a Pathway team is and what it does for patients in hospital. But we couldn't speak this morning. I spoke this morning about the patient view without hearing from someone who's been there and seen there and done that. So I'm very, very delighted to introduce our first special guest this morning, Matthew. Matthew is a volunteer with Pathway, part of our lived experience volunteer group. I'm going to drop the slide so we can how do I do that? Stop sharing so that we can see each other a bit better. Matthew, thank you so much for agreeing to join us this morning. Matthew's had the experience of being supported by a Pathway team and some other experiences. I think he may share some of that with you. He's going to tell you a little bit about his journey and how an interaction in hospital, I think it was St George's, wasn't it, Matthew?
Yes.
Made some contribution to how you are today. So Matthew, thank you so much again for being with us this morning. You're very, very welcome. I'll hand over to you.
Thank you, Alex. Yeah, thank you for inviting me. Good morning, everyone. Yeah, thank you for taking the time out of your day to listen to me. Yeah, my name is Matthew Courty, and I want to put a voice to the statistics you hear about homelessness. I want to show you what them numbers really mean, and how the right support can completely change a person's life. The homeless inclusion team supported me to make massive positive changes in my own life. Their guidance and knowledge of the system helped me in my recovery. I grew up around addiction and trauma, and in time I found myself struggling too. Life became chaotic and I ended up homeless, moving between hostels, hospitals and the streets. Over the years, I'd been discharged from hospital many times, usually straight back to nothing, back to the same people, the same streets and the same cycle. I was seen as a problem to be discharged, not a person to be supported. But in March 2024, everything changed. After being stabbed in my neck, my mouth and my right eye, I came frighteningly close to death. That moment could have been the end of my story, but instead it became the turning point, because that's when I met the homeless inclusion team. For the first time, I felt seen as a human being. They understood my situation and they didn't judge. What made the biggest difference was their knowledge and understanding. They saw that my situation wasn't just medicine or treatment. They understood the realities of homelessness, addiction, mental health, and violence. And they worked with me across all those areas to get me the right support. That's what made their involvement so powerful. They didn't just visit me once and move on. They stayed involved. They bought me clothing and essentials, made sure I had a phone and credit so I could stay connected, and remind me that I mattered. They helped me register with a doctor and liaise with them. They also helped me with the police, and they explored housing options. And they supported me to access benefits and identification. They connected me with legal advice, therapy, counselling, and rehab. They guided me through assessments and helped me make crucial decisions about my recovery. They also supported me through the court case after the attack, making sure I had the right information and emotional support when I needed it the most. Without their support, we wouldn't have secured a conviction. The perpetrator was sentenced to 35 years in prison. Without their involvement, I would have left hospital and gone straight back to the streets. But because of them, I was discharged to a safe place to start my recovery and not my relapse. That's what the homeless inclusion team does. They bridge the gap between hospital and home, between crisis and stability. They make sure people like me don't just survive, we actually start to rebuild. And the results speak for themselves. Since that time, I've been in stable housing, engaged with ongoing support, and I'm over 19 months sober. I now volunteer and mentor others, using my lived experience to help services better understand what it's like to be on the other side of the system. I'm giving back to society now, helping others find hope and direction, and proving recovery is real. And I know I'm not the only one. I've spoken to others who have been supported by a homeless inclusion team, and they all say the same thing, that the team helped them rebuild their lives and start their recovery. Now, not every story is a complete success, but every person is given a real chance. And that's what matters. Because with the right support, more and more people can find their own pathway out of homelessness. People can and do change, but only when the right support is there. The London Air Ambulance and St George's Hospital saved my life, and the homeless inclusion team helped me build a new one. That's not just a personal success, it's a financial one too. Because of the homeless inclusion team, I'm not returning to A&E. I'm not occupying hospital beds. And I'm not relying on emergency services. Their work saves money, reduces pressure on hospitals, and most importantly, it saves lives. The homeless inclusion team model works. It delivers better outcomes for patients, better use of resources for hospitals, and gives people like me the chance to break the cycle. and build a future. When you invest in a homeless inclusion team, you're not just funding a service, you're funding real recovery, hope, and human dignity. Thank you for listening.
Matthew, thank you so much for that this morning. And colleagues, I think you'll agree we needed to hear Matthew's voice this morning as we're talking about these matters. And Matthew spoke so eloquently about I mean, interesting about how much about that complexity, how many different challenges there are to be faced, and how that support helped you. Brought to mind, colleagues, the quote of Michael Marmot at the beginning of his book, The Health Gap. Why do we keep treating people and sending them back to the places which they came from and expecting anything to change? That's the simple question underneath the idea of a pathway team. So Matthew, thank you so much for that. Matthew's staying with us this morning, so is going to be here for the question and answer sessions. If you've got questions for Matthew, or indeed for any of us, as I said, please do post them in the chat. I'm going to bring back in some slides there. It feels we're going to return some numbers after Matthew spoke. It's hard to think of coming back just to the science evidence base, but we know the world we live in. We need academic papers and research as well as real life to persuade systems to act. So let me bring back in our slides. Hopefully you can see the slide set there. Let me move us on. I'm going to present to you a little bit of the evidence, the more formal evidence, which underpins what Matthew just spoke about. This focus, which I think comes through in his story of this idea of maximizing the benefit of an admission. When someone with high needs comes into hospital, let's take the most of that opportunity. So what is the evidence for the pathway team intervention? Well, on this slide, we're looking at patient outcomes. We have a quality framework. We train our teams to work on two of the key measures within that quality framework: reduced return to rough sleeping, 62% reduction in returns to rough sleeping among the teams in the program last year. Across the 8 teams, that equals 750 people whose time on the street was ended by their time in hospital. One of our other core quality metrics is a successful and appropriate GP registration being achieved for a patient during their time in hospital, so they leave hospital properly patched in to services in the community. Again, Matthew spoke about that. Chris talked about that in the story of Arthur. Also, a randomized controlled trial of the intervention published back in 2016 found that the intervention reduces street homelessness before and after the intervention of the team by a factor of 4, and crucially, found very substantial improvements in self-assessed health 6 months post-intervention. So this improves outcomes for patients, system-level outcomes in terms of efficiency and effectiveness. Across many reviews of the teams before and after, we find this pattern of reduction in A&E attendances in the patients. Summarized here as a 47% reduction in A&E attendances following the intervention of our team in this patient group. Another way to look at the efficiency is the reduction we see in bed days. So before and after a team goes live in a hospital, we see, on average, it varies a bit, but something like a 30% reduction in the number of bed days occupied by patients experiencing homelessness in a hospital because of the intervention of the team. And then the third study referred to at the bottom here, Khan et al., looking at pathway in a mental health setting, and this intervention works as well in psychiatric inpatient units. Zana Khan found a 50% reduction in total service costs in the 3 months after the pathway team intervention, with patients firmly and appropriately engaged with community services and community support, as Matthew talked about. And that's what we all want. And that's what a pathway team can help you achieve in your system. Here we summarize the cost argument. On the left there, standard care, as we say, estimate maybe about £5 million in the average hospital with an average number of homeless patients. Could be very significantly higher than that. A net saving we can see of about 1.1 million per hospital, and that's taking into account the £350,000 average staff cost of the pathway team that Chris described to you. But beyond the NHS, there are also wider system savings. Again, these are very cautious estimates in my view, But we know from our colleagues in the homeless charitable sector, it's been calculated that keeping someone on the street costs the state outside of the NHS at least £20,000 per person per year in all of the services which find themselves drawn in to engage. If a pathway team ends rough sleeping for just 90 patients on average per annum, there's a net saving there for wider public services, particularly for colleagues in local government, of at least £1.8 million per annum. So this intervention, we would say, is both quality effective, i.e. that it delivers better outcomes for patients, which is what we all want, but it is also very profoundly cost effective. Finally, in this section, the intervention also helps you comply with or meet an array of guidance and mandate, indeed legal mandate. There's a NICE guideline 214, which I'm sure you're all implementing, but the pathway team intervention is strongly endorsed in that. Indeed, the RCT is one of the key studies referenced in that NICE guideline. Health inequalities duties, Core 20+5, this intervention will help you respond to those mandates. There is a duty to refer on all hospitals in the country. You may know the 2017 Homelessness Reduction Act requires you by law to identify people experiencing homelessness in secondary care and to make sure they are offered the chance to be referred to a local authority. If you're not doing that, the pathway team will help you achieve and meet that legal duty. And finally, the medium-term planning framework published a couple of weeks ago, major emphasis on secondary care, on flow and on efficiency and maximising the use of secondary care resource. As Matthew said, this intervention, because of how it changes things for patients, really helps you add to the array of interventions you can put in place to improve flow and efficiency in secondary care. So we think it's a pretty compelling offer. But so how does Pathway as a charity help you? We are the National Homeless Inclusion Health Charity. How can we help you adopt and adapt this model to you? We've got 3 offers on this slide here. There's a bespoke consultancy offer, which again, just get in touch if you'd like some general advice or support around homeless and inclusion health matters, just do get in touch. We have a core team with a whole array of expertise in the world of homelessness and multiple exclusion health. So just please do get in touch and we can help you in all sorts of matters. 2 areas I want to focus on this morning are needs assessments and the Pathway team, the Pathway full partnership program support. To deal with that green area, the box on the right first, if you do choose to launch a service, we would encourage you to do it with us and to join our national partnership program. For members of the program, we offer a wide range of support, from scoping and designing the service to helping you with a business case. You have full access to an online manual, which will save you a huge amount of time in setup, but also full of training resources for the staff. We can help you recruit. We can bring lived experience to interviews. We can bring other expert staff to interviews. We have a data and monitoring framework. And we would join your team to our national quality network. So we keep going as Pathway to keep learning and keep improving the model. That ongoing support includes monthly support calls, network meetings, monthly masterclasses, and access for your frontline staff to our own set of experts who can help them perhaps with the most particularly complex patients. And then the box in the middle, needs assessments. And this maybe is a place we would recommend you start. I've got another slide on this. The Pathway Needs Assessment is a formal, you can commission us formally to carry out a needs assessment, a homeless health needs assessment in your area. And this will, as this slide shows you, help you understand what's going on for this patient group in your place. It will make recommendations about how other services can be improved and how the joins across the NHS and with other services in social care, in housing, how those links can be made. And it will help you generate the evidence to create a business case for investment to improve care for this population. Finally, our needs assessments always include gathering insight and experience from colleagues with lived experience, so again, to understand what's really going on in your place and what changes might help from the lived experience perspective. So that's the value of a Pathway needs assessment. But rather than me talk about that, we wanted to bring another voice to you this morning. As our second special guest, I'd like to welcome Cindy Fisher. Cindy is a senior manager from North East London ICB. She's a City and Hackney in the City and Hackney place-based partnership and as a senior commissioning manager for unplanned care. I'm going to stop sharing. Cindy, welcome. Thank you for being with us this morning. We've been working together, I think, for the last 6 years, haven't we? I think I first came and did a presentation in Hackney in 2019, and since then you've done the whole journey with Pathway, really, haven't you? You've commissioned lead assessment and moved on through to establishing services and onwards. Could you maybe tell colleagues a bit about, the value of the relationship and also that needs assessment process? What did that do for you, and maybe why was it right to bring Pathway in to do that for you rather than doing it in-house?
Good morning, everyone, and thanks, Alex, for inviting me to speak at this panel this morning. Yeah, it feels like a long time ago, 2019, but we knew historically that we had issues with delayed transfers of care within the Hackney-Homerton system. However, we weren't sure what to do about that necessarily, and we'd heard about the work that Pathway does and had engagement with one of the GPs who is part of the Royal London team, who is part of our local system overall. And so that audit really helped to identify the scope in terms of the numbers of homeless people attending A&E and being admitted to Homerton Hospital, as well as the City and Hackney Centre for Mental Health. It identified key themes and provided recommendations, which really galvanized us as a system into action. So that wasn't just the clinical commissioning group, that was partners at the Homerton, partners at the local authority, including both adult social care commissioning teams and the homeless prevention teams. I think a colleague of mine's on the call this morning as well from there. And that, I guess, enabled us to then write a business case. And we initially got 2 years funding from the clinical commissioning group, which we were at the time, and then proceeded from there. I think really the benefit of having Pathway do that work rather than ourselves was really about expertise and capacity. My colleague in local authority commissioning and I didn't feel like we were experts in this area. We didn't have the full knowledge, and then we also didn't have the time and the capacity. And I think our capacity as commissioners is kind of dwindling over the years as opposed to increasing. And so Pathway had a tested model for supporting an acute hospital to pull the data that was required, and the team to kind of pull our community partners into the conversation as well, which allowed us to actually fully understand our system needs.
Cindy, thank you for those words. Really, really interesting, and interested that kind of the value of having an external partner, I think, is one of the things to think about. And so where is the service now? Where are you at now? And I think we talked earlier about how you've had some drops in and out, and we've been able to help you keep the service going despite some adversity.
Yeah, we're now, I think in January, it'll be 4 years into our team having actually gone live. Pathway's been fundamental, I guess, in that time frame. We've had non-recurrent funding for that whole period, which has proven challenging, and that lack of stability has meant we've had people in the team who've left, and then sometimes challenges with recruiting in terms of short-term contracts. So Pathway's really been a consistent presence for me as a commissioner and for the staff at the team, in the hospital team. For me, you've done a full evaluation after the first year, and then helped ongoing supporting with data collection and analysis about the outcomes and the quality of the service overall. You support the team with things you talked about, but reflective practice, as well as ongoing training opportunities for the frontline staff. And then I think a nice side element is your role as advocates with government. You have a greater reach than any of us do as an individual system. And I am hopeful that work will result in more funding for all of us to be able to deliver better services to homeless individuals.
Thank you for that. Indeed, yeah, makes me think I was fortunate. In other words, fortunate was the right word. I was at the homelessness minister convened a summit last week where they didn't, but perhaps might have given us a snapshot of the forthcoming homelessness strategy. We've been lobbying hard to make sure that the links to health are in that homelessness strategy. So I hope we're meeting. Hope we're doing our best there, Cindy, and I hope we see something positive in that. Colleagues, I'm going to bring back some slides now, and then we're quickly going to have time to get to questions and comments from you. So please do be thinking of your questions. Let's just come back to the slide show. So just really following up what Cindy was talking about. This I hope you colleagues can see that. Just a quick example of some of the partners we've worked with. So Pathway are very experienced in this space now. We've worked across the country, north, south, east, west. We've done, as I said, over 20 needs assessments around the country. We've supported, I think there are now 18 Pathway teams out there, including 8 on our formal support network at the moment. So yeah, a tried and tested partner, you could say. A lot of experience both with health colleagues and with local government. Something about our support team, who you'd actually be working with if you want to work with us. As our slide says, my brilliant team, we have over 60 years experience in this group of people of delivering homeless inclusion health services, including very extensive experience of doing the job in the hospital itself. Chris, as I said, lead clinician in the Brighton team, has led that service for many years. Peter Buckman works in the Royal London. Other colleagues experienced in different roles in the teams, and lived experience in our own support team, of course, as well. Just draw your attention to the quote, everyone has different strengths and represents different parts of the system. That's our own support team, and speaks to the diversity that we offer you, that repository of knowledge about how you do this stuff for real. To summarize those benefits, you can read the slide here. The image on the right, Beacons in the Storm, is what we've called this year's annual report, published on Tuesday this week. That's Dr. Danielle Williams, who's the GP lead at the St George's team. She's had the experience of twice having to significantly re-recruit her service because of funding challenges, and we've been there each time to help retrain, reorientate, and restart the service, again without them having to go back to the beginning each time. As the NHS Commissioner says there from Kent and Medway, the hours and hours are saved by not having to set all that up myself from using our manual. So real value, we think, of us being an independent partner to you. And finally, our charitable status, I've put some things at the bottom there. We also always are trying to bring extra stuff to help the patients and to help you. Sometimes that will be funding legal advice or reflective practice. Sometimes we can get money for phones or clothes or things for patients. Sometimes one team this year, we've actually delivered them a garden from the Chelsea Flower Show. So a whole way we try and work and bring extra added value to the partnership. So that's the end of our formal presentation this morning. Time for questions. We've got about 15 minutes left. I'm going to stop sharing. I hope that's been interesting for you. I hope you maybe have learned a bit about what we do, how we might help you. So colleagues, yes, please, are there any questions about anything we've said this morning? As I said, Cindy and Matthew are still with us, Chris Sargent and I here, and actually some other members of our team are on the call. Any questions please raise your hand if you've got a question or questions in the chat.
We have 2 questions in the chat, Alex, we'll start with. First one, where does the funding come from? Great question.
I think perhaps, Cindy, could I come to you first on that, and then maybe Chris could come in on the more general. So Cindy, how's it been in Hackney for you? I know you've had a bit of a roller coaster there in terms of different sources of funding. Where does the funding come from?
Originally, the CCG at the time had some funding that I was able to access, but in more recent years, we've been utilizing the Better Care Fund, and within that, there was a discharge fund that was aligned within that. It's now no longer ring fence, but we still, as a system, use that funding. The money comes to both the council and the ICB, and we collectively determine how we spend that money. So the ICB pays for a 6-session GP, a nurse, full-time nurse, and an OT. The council pay, from their core statutory funding, they have a housing worker, and then through a discharge funding, also commission Providence Road to have 2 link housing workers, and we have a step-down bed through Peabody. So collectively, we have kind of a system just beyond the hospital team, and the hospital team reaches out into the step-down unit as well.
Thanks, Cindy. I think that's very common in our experience, that we see these blended arrangements of funding. It's one of the ways Pathway can help you is to think about other sources of funding, but perhaps non-standard, or trying to bridge a trusted connection between local government and between health to try and bring resources together into the same focused intervention. Chris, do you think that's right? It is often a blend, isn't it?
Yeah, so it's often that the local authority provide the housing worker element that the health system provide the GP. The trust may second the nurse into the team, or in some places the community trust will provide the nursing. So, and then support workers might come from a support work organisation in the community, like Just Life in Brighton. So sometimes it's a case of putting together different sources of funding for the different people and then bringing those people together as a pathway team in the trust. In other places, the trust have provided the funds. So if we've made a business case to the trust, they provide the funds to keep the team going. And in other places, similar thing, providing a business case to the ICS, and then they fund the team. But it varies from place to place, and we're happy to work obviously with all of those models to try and get a team going and keep it going.
At times in the past we've successfully, but we can't promise, but at times in the past we have leveraged charitable funds into some places to put some investment in the startup costs. So to meet those with external funding. We don't have that at the moment, but we're always on the lookout for it. So again, that's the value of the relationship with us, is that sometimes we can leverage funding in from outside the system. Won't usually pick up long-term revenue, but it certainly can make a contribution to the get-going costs. Paul, I think you said there were some more questions.
Yes, there is a question about the referral routes from primary care into pathway teams. Anyone want to talk about? A lot of our teams are associated with primary care services, aren't they?
Yeah. So obviously the teams pick people up once they're in hospital. So I think all the teams are happy to take referrals from anybody. So that might be a support worker in the community knows that somebody's coming to hospital. It might be somebody within the hospital. It might be a clinical person on the outside that knows the person's been admitted. And it's not just people who are rough sleeping, it's people, anybody with any form of homelessness. So those people are, staying temporarily, what people call sofa surfers. If they are staying somewhere that's unsuitable, if they're threatened with eviction, then the team will work with those people. So it's not just about people who are sleeping rough, it's any form of homelessness. And they'd be very happy to get a call from a GP or somebody in primary care or somebody in a day centre in the community to say that a particular person has been admitted, because even when a team's been in a hospital for quite a long time, the staff may not refer the person to the team. So it's really useful to get referrals from the community, and it also then means who the person is on the outside who might be supporting the person once they're discharged.
One of the other quality metrics in our quality framework for the teams is the time from admission to referral to the team. And we try to work so that the cases are referred to the pathway team as quickly as possible, which one has the benefit of getting the team as much time to work with that person as possible, but also brings the support alongside the ward staff as quickly as you can within that admission. And our teams, the teams on the programme now achieve very close to the target, which I think is something like 90% within 24 hours, which is really impressive and quite hard to achieve within a hospital. Paul, I think there's some more questions I could see coming up in the chat.
There are a few, yes. One's around the cost element to join the partnership programme.
Chris, do you want to handle that?
Yes, so the current annual cost is 27,500 plus VAT per year.
Very straightforward. And within that, so we're both providing that direct support to the teams, the staff team itself, but also, as Cindy alluded to, ongoing support for commissioners as we can, with data, with analysis, with evaluation and advice if other things are happening in the system. I see some more questions there, Paul.
Yes, there's one here about early intervention pathways before attendance, which I think we've covered a little bit with the answer about primary care. So I think we would take referrals from urgent treatment centres, and as Chris mentioned, we would. Oh, yeah, sorry, go ahead, Chris.
I was going to say yes, we take referrals from anywhere in the hospital. So if there's an urgent treatment centre within the hospital, then the team would try to cover anybody attending there. I think also in terms of early intervention, in some areas, the teams have developed the MDT approach to be able to discuss patients well, before they become patients, they discuss people who may be at risk of being admitted to hospital to try and put a plan in place so that they don't have to be admitted to hospital. But that tends to happen. I think the important thing is to get a team established in an area first, and then those sort of developments can happen afterwards. But that's certainly something that's happened in my area. So as our MDT meeting became more established, we realised that there were, because of the mixture of people that you had there, you were able to put plans in place to stop people needing to be admitted to hospital rather than waiting for them to be admitted and then put the plans in place. So again, that's something we'd perhaps like to do more of. But obviously that also needs resourcing.
Matthew, I was just thinking that kind of reflects a bit to what you talked about the kind of the team who you suddenly discovered were around you, and that there was lots of different expertise in that team, and you talked about that kind of planning with you. Is that how it felt, that you had this set of experts who were beginning to pop up and help with different things?
Yeah, definitely. Yeah. Yeah. Well, you know, you had someone who dealt with the violence, and they sort of seemed to know, you know, even if they had a connection with you know, with all areas. Yeah. So yeah, definitely. Yeah. Yeah.
So that bringing it together, and that's
yeah.
so nice to hear, because that's what we try and help them think about, but to hear that they're actually achieving that. And hospitals are not relaxed environments, really, are they?
No.
Mildly. Paul, let's come back to the questions.
Yeah, there's a question here about temporary housing being a challenge and how do we overcome these. I'm happy to answer that one if you want, Alex.
Sure.
Yeah,
so I should just so Paul is part of our support team. I haven't introduced him. Paul is the program manager for our support team, but also has 8 years experience as a specialist housing worker in a pathway team himself. So Paul, we are actually on the.
Yes, so temporary housing is a challenge. So obviously a big thing that our teams do is supporting statutory homelessness applications and providing evidence to housing teams around vulnerability, but also any other evidence that can help housing teams make quick decisions about whether emergency accommodation is the right thing to do. But they don't just put people into through the statutory homelessness process. They would also refer people to supported housing, a whole range of independent voluntary sector services. We also do a lot of kind of Care Act advocacy where people have complex needs, and we would look at any routes for people with no recourse to public funds. Again, looking at Care Act, Human Rights Act assessments, Section 95, Section 4 support where appropriate. And some of our teams also use legal advice to challenge housing decisions or immigration casework, get that progressed so people can resolve their homelessness as soon as possible. But it is a challenge, and our teams need to not only have a lot of expertise across the board, but they also need to draw in external services and external expertise for those really tricky cases.
Thank you, Paul. I see we've got a hand up as well. Sandra, I can't see my screen's not showing me your surname, but Sandra, would you
I'll just come in.
Can we unmute Sandra?
Somebody may have already allowed the mic. No, allow mic. Here we go.
Sandra, can't hear you. Might be able to unmute yourself now. Are you there, Sandra? Still can't hear you.
Sandra,
we've allowed your mic, so you should get it.
Yeah, sorry, I just.
There you go. Yeah, we've got you.
Thank you. What's the data trail around patients and how is this managed?
Chris,
in terms of, yeah. So do you mean in terms of keeping them recorded in the hospital? What happens when they're discharged? That type of thing.
Yes, I mean, how is it if you take Matthew's case, for example, given the amount of interactions between agencies and different agencies, how is this managed effectively and with respect to GDPR?
Sure. So once somebody is well, Matthew may want to talk about that in terms of giving permission for sharing of information. So yeah, you want to come in?
No, I don't want to come in. No, it's fine.
Okay. Okay, so all the teams take consent for sharing of information, and obviously it's up to people what information is shared with whom. So very careful about that. The teams communicate with the hospital teams via whatever the system is within the hospital. So recording in the hospital notes so that everybody knows what's going on, as well as having meetings and talking to people directly. And then when the person's discharged, it varies from team to team a bit, but in Matthew's case, the team are able to add on to a discharge summary. So they're able to write on the discharge summary what their intervention was, what they did, what the plans are, what needs to be followed up when the person's discharged. So that comes as part of the hospital discharge summary that a GP would normally get. The communication with other agencies would be more direct. So they would be ringing and talking to people, talking to the housing people, talking to any other follow-up that might need to be done.
I think part of our setup support for places is quite a lot of work on those IG issues, Sandra, to make sure that's right. And we have models from we're a place of sharing practice. So, for example, some of our teams have set up information sharing agreements with local authorities, with other agencies, and we've got a repository of those so we can share. Here's an example from somewhere else which may work for you. Some places they need to come up with their own. So that's the value of the support in a way. We've got that repository of knowledge about how to work through those issues. The issues are complicated and they're very important, but yeah, as Chris said, it's a core focus for us in the setup phase.
Sorry, could I come back?
Yeah, of course.
If you've got a VC SE organisation within the circle of care, shall we call it, how are they accommodated? The data, how's the data sharing accommodated there?
So through data sharing agreements and through the person giving consent for their information to be shared with that organisation. So when a person discussed at the, say, multidisciplinary team meeting, the person to be discussed, every person discussed will have signed consent for their information to be shared with the people at that meeting.
Okay, and sorry, finally, is it a standardized data sharing agreement or form or?
No, well, each area will have a standardized form that they use in their area, but it has to be negotiated locally because different organizations have different approaches to data sharing. So we always advise the teams to make sure that's approved by all the organizations that are involved before they start using it, because trusts have very different ideas about how information can be shared or should be shared. So that has to be different in each area.
I think in one of our London teams, I think it was the local authority who took the lead on data sharing, and I think their MDT has got over 100 people kind of protocolized to be within the MDT whose organizations have signed up to a data sharing agreement. But we supported the local authority in that instance to take a lead because they wanted to. So it does vary from place to place, but it's a crucial issue. Thank you, Sandra.
Did you say 100 organizations?
100 people come into the MDT or on the MDT email list, not 100 organizations, but 100 individuals, each of whom are covered, multiple organizations, each having signed up to a shared approach to data sharing. So they're all.
Thank you.
So within the meeting, they are all safely accredited to speak and to share information on the way in. So yeah, but it is an area of complexity for our patients because of the complexity of the issues that need to be dealt with. I'm aware of the time. I think I'm going to have to draw. We don't want to take more than the hour we crave for your time. So thank you for that question, Sandra, because it's a really important area for us. I've got a couple of slides just in closing. I just want to bring the session to a close, just to leave you with some final thoughts, but also what you can do. So as we've been saying this morning, we're here to help, keen to work with you. As I said, the business as usual scenario is patients circling around, ending up in hospital on a repeated basis, health continuing to decline, and yet we have a robust evidence-based cost-effective intervention which we can help you bring to your place, which can help break this cycle. So information here about how to get in touch. You can email the The email address is here, paul.hamlin@pathway.org.uk, Christopher Sargent at NHSnet. You can find us on the website. We will be circulating the slides that we've presented this morning. We'll send a link to our annual report and other materials. We'll send a follow-up email to everyone just to see if you'd like to talk to us. So again, thank you very much for giving us your time this morning. Thank you to Matthew and to Cindy for sharing your perspectives and your experiences. Particularly thank you to Matthew. I'm just going to leave you with a quote from one of the commissioners we worked with a couple of years ago. There's a lovely Pathway team now in Plymouth who are amazing, multidisciplinary team, care around the patient, working both in the hospital and again, sometimes where we've created a service that's helped to catalyse wider change in the system. And Plymouth is, I think, is an example of that. This is the commissioner speaking. In my 30 years of working, the most inspiring and proud thing I've ever been involved in is the setup of this team. We wouldn't have done it without your help. Every day together, we're saving lives, and that's what it comes down to. So I leave you with that thought. Thank you for being with us this morning. And do, as I said, please do get in touch if we can help you.